Thanks so much for joining today. I'm really excited to talk to you all about this. I'm excited about this conference and honored to be part of it. What I'm going to talk about today is really kind of a passion of mine. It's something that you'll hear in my story is a big part of my academic alter ego for my career that's outside of what I've done here at AMO. And I'm going to talk about something called the TeleOSCE. And really, it's about approach towards telemedicine training through clinical simulation, something that I've developed over the years and has come to prominence in U.S. Clinical education for telehealth training and competency. And so for this audience, I was thinking about how would this be relevant? Well, there's three things I think would be really relevant if you're coming from a different country or you're looking to come over here to the U.S. First of all, telehealth is a huge training model. You'll see some statistics I'm going to show. This is exploding all over the world. It's not just in the US, it's everywhere. And it was really pushed in by the pandemic. And so it behooves any clinical trainee to think about how he or she will be working towards getting training in patient-centered care through telehealth, because it's different than just jumping on a screen and talking to people. You're still delivering care, and this is what these simulations really help emphasize. Also, you're going to see what really has become a best practice in U.S. clinical education, which is the TeleOSCE. The AAMC has emphasized this format that I've developed as a prominent way to train for telehealth competence in the U.S. So you get access to this. And the cool thing too is all these cases I'm talking about are all freely available. So whether you encounter this in some kind of a training at home or in the US, you're able to get these cases and advocate for that and even try them out yourself. So really, I think there's lots of utility for being on this, and hopefully y'all will agree after this is done. So some quick agenda here, some background on me. I'll talk very quickly about me. Give you a little, I've already kind of alluded to it, why telehealth training is really important for any clinical training, and clinical, medical, nursing, whatever you're doing, it's important. It's part of our training model now. Then I'm going to deep dive into what this is, because really this talk is about a pedagogical approach towards training clinical people on telehealth through experiential simulation. It's something that I came up with, and I'm going to talk about that process, how it started, and where it's gone, because it's evolved over the years. Talk about all the different people that have utilized the TeleOSCE format, some research that really helps give some credibility to this format being a good way to help learn about telehealth, and hopefully have a little time for some discussion or some chat. So again, I cannot see the chat right now, so please pop them in there, and I'll be happy to answer them when I'm done. So a little bit about me, as I've alluded to. First of all, at AMO, I'm the head of clinical partnerships. So I really work with the U.S. Clinical healthcare systems and hospitals and doctor groups and whatnot to truly try to build capacity for AMO and AMO students, so we can get quality rotations at these broader institutions, and that's what I do. And that really is a good, it comes from my years of experience in medical education. Primarily, that's been my career. I'm a doctorate of education. I'm not a clinician, but I've worked with clinicians my whole career. And I've really worked as basically the education partner with them, and helped develop educational curriculum and content in conjunction with the clinicians that for high quality learner experiences. And that's been all over at I've had several different positions at U.S. Medical schools. I've worked in a Caribbean medical school, and most recently I was Associate Dean of Medical Education at Northeast Ohio Medical University, which is an LCME accredited community-based medical school here in Northeast Ohio, where I reside. And really, what I'm going to talk about is a lot of my work around online synchronous space. Now everyone jumps on Zoom, but when I started my work and my dissertation work, actually back in 2010, it was very rare to do this kind of work. Now we all do it, but I really kind of got interested in the kinds of potential that we could have in these synchronous online spaces versus what would be like a chat room or a board or something that was more asynchronous. That was kind of the norm back in 2010. And then I'm going to, I was the person who came up with this thing called the TeleOSCE. It was my idea. it's kind of gone out there, but really I originated it, and I say that not that I'm the sole person who's done this. I've collaborated with tons of different people. I couldn't do this work without the collaboration of my clinical colleagues and other educators. So, but it was kind of my idea, and I've pushed it to prominence, I think, with some of my academic publications and presentations, and this is one of them. So I'm not going to go over all these, but this is, you'd have to not have read anything in the news, foreign or domestic, depending on where you live, that to know that telehealth has really exploded. And that really was fueled by the pandemic. It was kind of a sideshow when I started doing this, and now it became the main event when people couldn't physically go into their clinics. So everyone started saying, well, I still need to see my clinician, so we got to use telemedicine more. And so these are some a little outdated numbers now, but they really were taken as a snapshot in the pandemic about how the explosive rise in telehealth, and it went from like the third bullet, 250 billion industry in 2020, from a 3 billion industry before, so I mean, it just exploded. And that was because everyone needed to use it. And then consumers really liked it. And I'm going to call myself a consumer of healthcare. I've used telehealth. It's wonderful. As a parent of 3, it's absolutely wonderful. And it's not the end all be all, but it's a great alternative model to going in and seeing your clinician. But really the game changer was in the US, at least Medicare and Medicaid services, CMS basically said, hey, we're going to start reimbursing clinicians for this now in a way we didn't before. And that opened up the floodgates for everyone using it. And because of the popularity, because of the access gains, those floodgates aren't closing. Those have stayed open and have been more and more cemented. So telehealth isn't going anywhere. It behooves any trainee to learn how to use this, because you can't just jump into it. It's different. The second big game changer was the AAMC, American Association of Medical Colleges, created a set of competencies. So when I started doing this work, we didn't really know what you needed to do as a future clinician in using telehealth. We just kind of guessed, and I say we, meaning my physician colleagues, and I said, look, these are the things that we think a physician should be able to do to deliver patient-centered care using technology. So we were guessing a lot. But then the AAMC got together a lot of really smart people, and over a 2-year process, they built a set of competencies. These are paraphrased, and I'll have links to where you can get these, but they're under these domains are real, and these are kind of what they get at. But they basically said, look, here's what every learner entering residency, every resident entering practice, and every practitioner should be able to do to deliver telehealth in a competent, patient-centered manner. And so by publishing these, and then they disseminated them to hundreds of people, myself included, to vet them. So they got a really wonderful process, and they came up with wonderful competencies. And I think what that does now for educators is it gives everyone a benchmark to say, this is what we should be training students, physicians, residents to do in telehealth. So it's really changed the game, and you're going to see a lot more telehealth educational content now because of it. So those are the reasons why it's important to know. And so let me now jump into this TeleOSCE. Okay, so I'm going to go now into the genesis of this, which I talked about, really started in 2013. I started doing my online work with med students in 2010, but the TeleOSCE I really came up with in 2013. Now, first of all, some people say, what's an OSCE? Some people don't know. Well, objective structured clinical exam. Essentially, when you go in and work with a simulated patient, an actor or somebody playing a patient, and you have some kind of an encounter that's scripted, but you as a clinician in training are going into that and acting as if you are the clinician, right? And this is a popular format in all clinical training, whether that be medical or nursing or physician assistant. Everyone does these types of things. So that's what the OSCE is. So TeleOSCE was a telemedicine OSCE, clever way of saying that. The genesis was 2013. I was working in distance education, really. I was working with a group of third-year medical students at Oregon Health and Science University who were in very remote parts of Oregon. Most of you might not, from an international audience, might not know where Oregon is, but it's in the upper left part of the US. The eastern part of Oregon is very, very rural, and we sent students out there, and we were connecting them through technology, and this was, again, very new at the time. Now, having been successful at some of these synchronous events with these students, I said, why should we should deliver a clinical simulation to them because we don't see them for months almost, and we want to see how they're doing clinically from the mothership right back in Portland. And so I said, let's use this format, and then let's do a clinical simulation, but let's do it all through the computer. And really the form followed the function. I wasn't thinking let's train them, teach them how to use, do telehealth. I was thinking let's deliver this content to them. And in what situation would a learner or a clinician be talking to a patient via their computer? Well, telemedicine. So let's make it a telehealth simulation. So that's really how it came about. And then I said, well, these people are sitting out there in rural Oregon, and like any, this is an underserved area. And, let's teach them about the potential of telehealth to help the populations that they're encountering out there. And certainly telehealth is huge for our rural communities because it delivers care to places that care doesn't exist in person. So let's teach them about that. Let's also not say, hey, we're going to teach them how to use a specific telehealth system. First of all, I didn't have access to one. OHSU didn't have it. Well, they had one, but it was very, very, very sophisticated. Let's be more important about how they're delivering care via a telehealth medium, not what they're using. So really, what are the competencies someone should use? So we actually used Adobe Connect, which is now defunct, I think, but it was one of the the synchronous kind of like Zooms of its time. So let's use this. It's not even a telehealth platform, but we're going to use this to simulate one. And what we're going to do is we're not going to teach these students about how to do this before they do it. We're just going to throw them in. And from my educational background, that's a type of learning called assessment for learning. You learn by doing, and then you debrief on it. And by doing that, you learn lessons. So the next time you do it, and for real, you have those lessons. It's kind of like flight simulation for military pilots. They don't just jump in an F-16 and fly it. They do lots of simulations beforehand before they actually get in that thing. So it's a similar concept. Again, we delivered it through Adobe Connect, but we made it so, hey, this could be on anything. So now, you'll see some of the work I'm doing now. It's done on Zoom, but it can be done really on anything. At the time, I think Skype was the popular one. We said you could use Skype. And then most importantly, we said, let's do it in an online only and in-person setup. So how did that look? So think about it now. You've got learners all over the state of Oregon. And this is just kind of we did it via the cloud. Now, again, now that's not a crazy concept, but go back to 2013, it was kind of. So, you had, this is what we needed for these simulations to work. First of all, on the right, you need the student who would be out there in Eastern Oregon. Then you need the standardized patient. So the person playing the patient, he or she usually was at their home in Portland. Then we had faculty observers real time watching it, how we did it at OHSU. So they were coming in often from their offices or their homes. And then, I was the staff support at first, but as we expanded, other people did it. But the cool thing about this was we learned, hey, we could administer this completely online. We don't have to come into a simulation center. So we did that, and we did it successfully. Now, the success of it begat other interest at OHSU, and they said, well, let's do this for everybody at OHSU. So we started doing an in-person one. Well, how's that look? So basically, this is utilizing the Sim Center. I think this is at OHSU, but we do this at University of Oklahoma-Tulsa, where I'm doing some work on this now. Now, instead of the students were doing different cases in different stations. And so just one of their stations, when they walked in the room, they didn't see a physical patient in there. They saw this. They saw the computer stand with the standardized patient on it, and the student sat down, and there was the prompt outside the door, and they did the whole case just like this via telehealth. So that was the in-person version. So the utility of it was immediate in how we can do it. So our original scenarios, and these are the ones that I did at OHSU, and they're important because they were the only ones for a while. Now this kind of changed, but we did 4 cases, and again, we always thought, let's make these very contextual. So we're gonna make these about the patients that these students are seeing, and also the potential of how they could help these patients with common ailments that patients in these areas were facing. And these are all, if you've noticed, they're very primary care focused because I am still a faculty member in family medicine. And so we are creating in primary care types of cases. So the first case was a foot sore case. I'll jump into that a little bit because I think it's important that you see what these actually are to really understand it. But it's a diabetic foot care management. We then had a trouble sleeping, which really was a depression case. That's actually published on MedEd portal, and I'll give resources for that at the end of this. Then we got a grant from the American Board of Internal Medicine to teach some of their choosing wisely guidelines. And so we picked a knee pain one, which was improper or proper use of MRI imaging. And then we did a sinusitis one, which we actually made an urban underserved, our first one. And we actually had the patient using his or her cell phone as their camera, because a lot of urban underserved so low socioeconomic patients, that's the only internet access is their cell phone. And so we wanted the students to understand, hey, this is how you have to do it, so that and how do you talk to a patient when they're on their cell phone. And that was about a sinusitis case. Now, what's really important, and this is why I think it's the TeleOSCE has gotten so far out there and utilized so extensively, is because I built them to say, let's kind of have a underlying format things that we're looking at in these cases. So all the cases will have some element of this. So first of all, every case, of course, is going to assess some form of clinical competence. So how should a X level learner, resident, undergraduate, practitioner be able to perform clinically with this case? So we wrote these for medical students, but they could easily be scaled up for residents. In fact, they were, just make the clinical stuff more sophisticated, right? But then always in every one of these cases, let's introduce these students to the socioeconomic competencies that they need to master depending on this patient population. So for instance, in rural Oregon, there's always transportation issues, which you'll see with this case. Oftentimes in these rural communities, they don't have a pharmacy. They have poor access to fresh food. So a lot of students would say, hey, you should eat better and eat more vegetables. And we'd have the patient say, well, I don't have any fresh vegetables in my town. And that was a real thing out in rural Oregon, and frankly, all over the world in rural areas. And then the limited internet access, telling them that that this isn't something that everyone just has, and so we throw technology issues in. But then we introduce these patient-centered use of technology competencies. So best practices, for instance, looking at the camera is looking at the patient. That was something we do, and making sure the patient can see you, all these types of things. And then what I think is really the hallmark of these TeleOSCE cases, in every one of them, there's a stumbling block. Now, even in this conference today, there's been some stumbling blocks, because when you have technology, you have issues. That's just the way it is. And so we introduce some form of a stumbling block in every one of these cases. I'm writing cases. The cases I write now, I still always introduce a technology stumbling block, and you'll see what that looks like. So let's go quickly into this foot sore. So what's this actually look like? Well, here's the scenario. Don Baker's a 74-year-old diabetic. He lives in Crane, Oregon. You'll see on a map here how remote this is. His primary care provider is in Burns, who set up a telemedicine portal for this patient. And the closest hospital is 200 miles away. And this is very common in these areas. He's calling about a sore in his right toe, but he's not going to just drive to Bend, because when the student sees this picture, which I'll show you, they said you should really see someone besides just a clinic visit. You should go to Bend, Oregon. But the patient refuses, because he went to Bend a month ago, cost him a lot of money to drive that far, and he's not going to do it. So the student has to see what's going on, assess the severity correctly, is to utilize technology with the stumbling block, and then work with the patient on a treatment plan. And so here's, if you can see, there's nobody out in these areas. Bend is fairly populated, but Burns is sparsely populated. Crane, there's nobody. So you can kind of see where this patient's coming from. And this is what we get the students in rural Oregon and in Portland to think about. Like when they'd be surprised when this guy said, I'm not going to drive from point B to point C. Are you crazy? That's a long way for me to go for something that last month was just a blister, right? And so it's a real issue. And so what happens is, this is kind of a gross picture, but trust me, there's worse ones with diabetic foot sores. Basically, the students had never been on this technology before. And in Adobe Connect, there was a way for them to download an image in this technology. We'd never taught them how to do it. They might have never used it. But when the student would inevitably say, can you show me a picture or describe this foot sore to me? The patient would say, oh, I uploaded it. It's it's on there. And then it was said it is footsore.jpg. So the student would have to download it, but then it would open up in a whole nother window. So it would throw them off, right? And then they would, but if they didn't, they wouldn't see this picture and say, hey, this is severe, this is actually concerning. So there's a lot of things we threw at them, and that was that stumbling block. So I don't know if this will play. It's only a few seconds, but this is a student actually encountering that stumbling block, because it's so critical, because this patient is still on the other end of this visit. If he isn't getting cared for because the student or the doctor is frustrated by the technology, then that's a loss. That patient's still there. He doesn't care about your problem as a clinician not knowing the technology, and that's what we try to do. So let me show real quick.
Excuse me, how your foot's been going. How have your blood sugars been for the last couple of months?
They've been kind of climbing up.
Okay.
So to the
In fact, I uploaded a copy of that for you from my record.
Oh, all right. I think
you find that?
I think so.
Yeah. So the student who's on the right is basically going over to the, I don't know if you can see my pointer, but to the right part of the screen and downloading that. And then again, it opens up in a totally different screen. And some students would get quite thrown by it. Some didn't, but it was in the debrief, it was saying, hey, technology is not always going to work. What are you going to do about that when it doesn't? So that's part of it. The standard, straightforward, you can kind of see there's interpersonal communication, there's use of technology, there's clinical knowledge. So we're assessing those competencies that I talked about. So that's the TeleOSCE format. It's important because it's hard to, I think, conceptualize when you're just talking about it. But we created these, and then we started to publish on them, as you do in academic medicine, and we started to go to conferences, or I did, and I started talking about them, and people started getting interested. And then we wanted to do some research to say, is this actually effective or not? Is this something that's valid or is it not? So I'm going to talk a little bit about that dissemination, because I think this is really, really where you might have already encountered this format in some way, shape, or form. So, I mean, these are just known efforts, ones that I directly collaborated with people on. There's a lot of people who've downloaded these cases, and I know have implemented them because I get emails all the time. But, we worked with the University of Texas Health Center, San Antonio. We worked with the University of South Dakota's rural program. We worked with the PA program at OHSU. We worked with the University of Central Florida. And then we actually did a research study with a residency program in California on this, using these cases and then scaling them up for a residency population. And then most recently, some of my work on still my academic consulting work is I've been working with the University of Oklahoma-Tulsa on, I think, probably the most ambitious implementation of the TeleOSCE format that I've worked on since my work at OHSU. And in fact, I think this is more ambitious because it's more deliberate and it's utilizing a lot of the research to really kind of step up the game on this. Now, first of all, I'll step back and say the time between this, I left OHSU and I went to the American University of the Caribbean, and I started working more in upper level administration in the dean's office. And I really didn't do this work much anymore. I kind of got away from it because I was putting out fires at a medical school, 2 different medical schools for several years. And what happened was COVID happened. And once COVID happened, then all of a sudden I started getting emails, and the AAMC came and asked me to do some talks and asked me for any case I had. Because what happened was all of a sudden all these schools had to pivot quickly and say, we're going to be online. How do we deliver a clinical simulation via Zoom, right? So again, they might not have been even saying, I want to do telehealth. They were just looking for resources that were kind of more polished, that they could disseminate to different programs, say, hey, you can run this case. It's a telehealth case, but it's a good way to assess clinical competence. So all of a sudden it just exploded. And then that really begat this work with Tulsa. I was doing consultancy work prior to my time at AMO. And basically what we're doing, and I say doing because it's still current, is we've taken a curriculum and basically said, we're going to use this format, the TeleOSCE, in a longitudinal format across a year to assess 10 of those AAMC competencies that I talked about earlier. We're going to do these competencies at several different points on several different simulations, and we're going to map how learners progress on these. And we're going to write a bunch of new cases. So these are all new cases I wrote with them. So we wrote 3 TeleOSCE cases, basically, which are kind of like the one I showed you, which are more robust. They integrate lots of different circumstances. We did a hypertension case that incorporates website manner, and that really focuses on a big tech failure. That was a big part of it. Tech failures are inherent to all of these, but that was a big one. We did a mental health suicidality case for patient safety. That was we did for their psych unit. And then we did a med rec case, which really basically got at team-based care and also health literacy, social determinants of health. So those are 3 cases that we wrote last year and implemented. We also did something that I hadn't done before, which was said, you know, telemed is blowing up right now. There's more than just these kind of interview cases. And first of all, people say, well, you can't do physical exam on telehealth. But in fact, you can. You can do things because people are doing it all the time. My son had a skin rash or something, and I did, you know, a telehealth visit, and this is a real story. And the doctor looked, he had me get the camera close to the rash. He said, oh, okay, I know what that is. I'll get you some, you know, antibacterial. It's at your pharmacy right now. So he did a derm exam. That's a physical exam, right? He did it on telehealth. So this is happening. So I said, we should be doing this. So we basically had 3 teleskills, which are more stripped down cases. They're more straight to the point. And they said, hey, you're going to have to be innovative here, but take vital signs, you know, and do an ENT exam. And so we give them some things, but the students, they'd have to be a little innovative. Like, hey, can you open your mouth and say, ah, and hold it up close to the camera? So this is what we're teaching them. We also did the skin exam, so derm. Then we did we're going to do musculoskeletal coming up, and then we did a concussion assessment too. So these are really cool things that we're doing there at Tulsa. And the cool thing about that is, if you remember those competencies, it's hard to, this looks like a bunch of gobbledygook, but essentially this is all those different PA and MP. So this course is for M3 learners at Tulsa and PA2. They're in a combined class. They come in once a month during those clinical years. And what this essentially does, and you can actually filter this, so it's just one student, but this is showing all of them. This is how these different students performed, and every one of them has a different line against an average over these different competencies over time. So we've built dashboards on this. So this is one, basically we're trying to say, hey, these AAMC competencies are great. Let's use the TeleOSCE format to double down and say this is a valid way to assess these competencies. And the reason we can say that is because of this. So I've got a couple publications, but I think this is the most important one. You know, this is now step back to OHSU, we're running these cases for these now, not all now in the family medicine clerkship at OHSU are now doing a TeleOSCE case, most of them in person, like I showed you, walking into the room. But some of them, because of just the way that the years lined up, weren't getting it. So we said we can now have a control group who's been exposed to the TeleOSCE and one that hasn't. This was not something we pre-planned. It was just the way it was. So we weren't, you know, they weren't going to get it anyway. So we were able to have that comparison group without denying anyone anything. So we said, let's do a longitudinal study. Let's do a pre and post. So at the beginning of the clerkship and at the end, and then the exposure will be the TeleOSCE. So we got a survey from University of California, Davis, that had done something, they built this, we adapted it a bit. They had a robust telemedicine program. We basically said the survey gets at student perceptions of their competence in, knowledge of, and attitude towards telemedicine. 17 questions on a Likert scale. And we collected data from 2014 to 16. So it was over a couple years. And then we basically said, week 1 at the orientation of the family medicine clerkship, we administered this survey. Then about week 2, the students got the TeleOSCE. Some of them got it, some of them didn't. It was really only the first year where they didn't get it, and then everyone got it. But we had that comparison group, and then we re-administered that same survey with names matched at the end of week 5. And you know, there's 7 or 8 different rotations per year. So we had an N of total of 172. 140 were active participants, so those are ones who got the TeleOSCE. 32 were inactive. So again, we weren't denying people. These were just 32 because of scheduling, they weren't able to get it. And what we found was this. So this is these are basically the active participants. The ones who got the TeleOSCE are in orange. The ones who didn't are in blue. The wider the spider graph means the greater the difference between the pre and the post. So you want in this survey, if our hypothesis is correct, that doing the TeleOSCE will improve your knowledge of, confidence in, and attitude towards telemedicine, you want to see a wider spread. So what you can see from this is that the people who didn't get it had much less change over 5 weeks than the ones who did get it. And what we found was, in terms of significance, there were significant differences in the general categories of knowledge of and confidence in. The attitudes towards, there was a growth or a change, that was, but it was just non-significant statistically. And of course, there are limitations of this, a small control group, self-reported data, and the survey wasn't validated. However, there's literally nothing else like this. So it basically gave the groundwork for this might be a valid format for teaching telehealth. Getting close here, which is good because we're only at the 30-minute mark, and we can field some questions. Resources. I talked earlier today about, hey, you can get this, and if my slides are available, you can download this. If not, jot down these names because you can find this stuff. Again, like I said, these probably academic medicine wonks who like to read about this stuff were finding my work before on these cases, but it wasn't that big of a deal until, again, COVID said, hey, everybody needs these. So once that happened, people were really, really interested. And so we had already published on MedEd Portal, which is a peer-reviewed online resource by the AAMC, freely available, wonderful resource for educators, but also for anyone who's looking for resources on educational resources. The depression case was published there. And then iCollaborative is a non-peer reviewed, but it's just a way of getting digital resources up there quicker. And they said, give us all your cases and we'll publish them there. And then I actually wrote a dental health case with a dental professor colleague of mine. So these are all available on iCollaborative and MedEd Portal freely to download. You can see those cases I talked about. And then actually, I did a couple talks on these things, and they had me come back and talk because during the pandemic, these cases were the most widely downloaded resources on iCollaborative, period. There was no comparison because so many people needed the resource. And the webinars there. So AAMC really held, when they were talking about these are resources you can use to teach telehealth, they actually pointed to these resources and said, this is what you should be doing, especially the MedEd Portal one, the depression case, because it was peer reviewed. Also, too, those OU Tulsa cases, they're freely available. We're in the process of publishing those on MedEd Portal, but if anyone was interested, just an email I could release the cases. They're quite good cases. Some publications, there's more coming, especially with my work with Tulsa, but these were some of the earlier ones. And so I'll end by summarizing, why this is important. Telehealth is only going to continue to grow. And if you think about smart monitoring devices, which are already in the wild, think about diet glucose monitors that connect to Wi-Fi and give your providers your A1C levels or patients panels and whatnot, then that's part of telehealth. And so that's going to emphasize the data that a clinician has when having these experiences. Instead of just talking to somebody via their camera, it's going to get more sophisticated. Therefore, the need for clinical training on how to deliver telehealth competently is only going to grow. And I can tell you right now, at least in the US medical education, it's not really being taught evenly. I think Tulsa is probably the best example of a medical school really doubling down on this stuff. There's other programs out there. They tend to be a little more functional in terms of this is how you use this kind of telehealth. But when we go to I've been to conferences on that, people are quite surprised at how much we're doing there. So, this is only going to get more and more important. I truly believe that assessment for learning using this format provides a wonderful context for any learner at any level, whether they be a first-year medical student or a seasoned practitioner, to learn by doing, to get their feet wet, because this isn't intuitive. There's good ways to deliver care via telehealth, and there are not so good ways, right? And there's different dangers inherent. For instance, when we do our suicidality one, that simulation, that patient who could be suicidal is on the other end of an internet connection. If they click close, they're not in the clinic with that practitioner. You can't intervene. So there's different things you have to be able to do when talking to someone. And I can tell you, mental health is the most popular utilization right now of telehealth, and will probably continue to be. So by making this low stakes, experiential, it gives people a chance to mess up and get their feet wet and not be perfect, because that's why we learn, right? And we forget that sometimes. And so it's a wonderful way to get people working and debrief on that. The cool thing about these is, because of the way they're written, they can be modified. You can make it more difficult clinically. You can make it more difficult socioeconomically. You can make it, you can say, hey, this took place in Oregon, but I can make this take place in Oklahoma or in India. It doesn't really matter. You can modify them. And again, you can administer those in person or totally remotely, which really opens up a world of possibilities in terms of scaling this. And we're actually thinking of doing this at Tulsa. You can make these high stakes. Absolutely. You can make this, hey, we're going to give you a summative OSCE, which a lot of OSCEs are. There's no reason you can't. And perhaps they've been used that way in other contexts. I haven't done it that way, but they certainly can. And again, these AAMC telehealth competencies are going to help institutions, individuals, practitioners, whomever, implement curriculum that prepare learners for not future, but current practice models. It used to be a future practice model. It is a current practice model. It is in the wild. When I'm at Oklahoma, students said, well, they were skeptical about using it. And I opened up my app for my insurance on my phone. And with 2 clicks, I showed them how I could get onto Teladoc and get a telehealth visit. So I told them, if you don't think this is coming, think again. That your patients will demand this of you and your clinic. And again, these competencies are developed for learners, residents, and practitioners. So really, everyone should be able to utilize this. That is my contact info. I'm on LinkedIn. I'm on AMO, and I'm very excited to talk to any of you. So let me jump now into some of the questions. See if we have any, and that's fine. Let's see. I see. How do I register for a TeleOSCE? So, right now, there's no one centralized place to get this. Again, think about it like if you go back to online learning. When it first started, there's probably only a few places that were doing this. And it wasn't like they invented online learning. They were just using the internet to deliver education, right? And then it started growing, right? And more people started offering it. So you might have only been able to access it at a certain school at first, but then the model disseminated quickly. That's kind of what's happening with the TeleOSCE, because when you think about it, it's just a clinical simulation via telehealth. Now, I will say, I think I'm working with different schools. I think we're interested even as a company in terms of helping schools build simulations like this. So if you're interested in this, I would Google it. I would look. I'd see if there might be other places that are actually offering this to the general public. But at the very end of the day, I'd say keep an eye out for opportunities, and then also go and download the resources and go back to your own context, your own schools, and say, can we do this? They're not hard to implement, and we've built them in a way that anyone could just kind of plug and play with them, and with some minor modifications. So, and I do think this format, it is already happening. There'll be more and more opportunities to get this. And the LOR question really isn't relevant. How do you take vital signs virtually? So that one's interesting. So there's lots of different ways you can do it. There's actually smart cuffs and vital sign monitors or whatever. Like you can actually buy those. There's very few things you can't do with a smart device now. It's an exploding part of the medical device industry. That said, it's oftentimes those devices are for very specific rehab programs. There's a lot of really interesting stuff with elder care and rehabilitation that's happening around these devices. But again, that's more specific. What we do at, I'll stop sharing this. What we're doing at Tulsa, because again, we contextualize it, and the University of Oklahoma-Tulsa is a community-based medical school, and their clinical enterprise there that the students rotate at is a uninsured clinic. So these are very poor patient population that don't have insurance, and so we wanted to make these cases relevant. So we basically have the students walk the patient through taking their own blood pressure and then reporting back what they're seeing, and then using that information plus leaning in with the ENT to kind of cobble together that this patient is okay or not. And so it's what I call a lo-fi way of doing it. And we give them some clues, but we don't give them all, because part of what we're teaching them is, hey, you're doing a telehealth visit. You don't know what the patient has in his or her house. Maybe they have a cuff, maybe they don't. You need to ask. And this happens. I mean, I've done telehealth visits. I mean, it's like that, you know, and I've talked to lots of physicians who do these. You know, you got to be a little innovative sometimes with this stuff and a little creative. So that's how we have them do those vital signs virtually, that case. But there are devices, and we flirted with the idea of actually introducing them to some smart devices too. Yeah. Okay. I got to go back. Okay. Let's see. Did I get it? Okay. Do you work with schools in UAE? I mean, me personally, I have not, in terms of my academic work or my consulting work. I know AMO works with that. So yes, we absolutely do. And, you know, part of me being on board at AMO is, you know, is I think helping to work with some of our partner institutions and our colleagues in our clinical systems to develop resources like this that we could then turn around and offer to a worldwide population. So I think some more on that later. But if you're certainly interested in talking more about this or getting this to a school in the UAE or anywhere else, all you just feel free to hit me up on LinkedIn or shoot me an email, and I'd be happy to share whatever resources I can and have a conversation. I have a couple more minutes, and if there's no questions, that's absolutely fine too. Great. Well, I'll conclude with this and just thank you all for attending. It's really wonderful to see so many people interested. Again, this is a passion of mine. I believe telehealth is not a replacement of in-person care. It's just an extension. And if we're not, we have to be innovating and moving forward, and that's what telehealth is doing. And it has the ability to really help a lot of people who didn't have that ability to be helped before. And for all of you as future clinicians, I just encourage you to keep it on your radar, to get to remember that when you're talking to a patient on a computer, for that patient, you are the provider, and you are as important as if you were in person. And that patient needs your care just as badly via whether they're talking to you in person or via a webcam. So please always remember that the patient comes first, and deliver that patient-centered care no matter what the context. Thank you all very much. Enjoy the rest of this session, and I'll talk to you later. Feel free to hit me up if you have any questions. Bye-bye.